Hi, I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome to Fluid Matters. It's a special mini-series looking at all aspects of perioperative fluid and hemodynamic management. This is another clip from Controversies in Perioperative Medicine organised by Duke University Medical Center in the USA, recorded in June of 2018. This is from the Great American Fluid Debate. Now, the longer piece here was about the controversy of liberal versus restrictive fluid therapy. But within that, Dr. Tim Miller from Duke proposed a question about the habits of having patients starved and therefore nil by mouth preoperatively. And then the rest of the panel, that includes Stuart Grant, Professor Mike Grocott and Paul Wischmeyer, with me in the chair, goes on to discuss that actually we've considerably changed our approach to this now, and patients are increasingly being allowed to drink clear fluids till the very last moment prior to going for their major surgery, as this is now thought to actually reduce risks around the time of surgery. Top Med Talk.
I'd love to debate NPO status a bit more, and we've perhaps come on to this, but we've changed it at Duke, and several hospitals in the UK now have completely removed any restriction to preoperative water.
Yeah,
i.e. you have this by your bedside in the pre-op area, and you are encouraged to drink.
So Great Ormond Street Hospital, National Paediatric Leading Hospital, has published recently they've gone to zero NPO for clears.
And there's some physiologic basis for that, right? If you don't increase the volume of the stomach at any point over the night they're NPO, the stomach won't empty. And they're finding with pre-op carb load to actually get the stomach to empty, you have to distend it a little bit. That distension actually causes better emptying, so pre-op carb loads lead to lower gastric volumes than people who are left NPO more than 12 hours.
Okay, I think we've got our first question from the floor. I think it's Eleanor. If you could tell us your full name, Eleanor, where you come from, that would be great.
Elena Patterson from Asheboro, North Carolina. And I just had a question from your talk about the carbohydrate load before surgery. 2 hours before?
Correct.
Where does the protein come in?
So the carbohydrate load piece is just that. It's a carbohydrate load.
And what is it?
So it's 50 grams of maltodextrin, 45 to 50 grams. There are commercially available products in the U.S. that you can get for a few dollars that patients can drink that actually have exactly what was studied in the mostly European studies that have been done. And it's literally it's 50 grams of maltodextrin. And it doesn't have protein or other amino acids in it. We've dreamed that would be such a great thing if we could add a bunch of amino acids to it, and maybe someday that'll become reality, but right now we have great fears that addition of amino acids, especially arginine or citrulline, potentially could cause delayed gastric emptying because they generate nitric oxide, which can slow the emptying of the stomach. And so we need a little more data before we can say, boy, let's start throwing protein in. The protein piece happens in the weeks before surgery, where we're delivering a high-protein oral nutrition supplement daily for 10, 20, 30 days in that lead up to surgery. But the morning of, and I know Monty and Mike, you guys do it the night before, the 100 grams, which is much more marathon runner-ish, like all of us that have run marathons or run races would take in that kind of load the night before a big race. Surgery is not any different. That would improve your fluid balance in the morning of, too.
And to everyone who's going to comment on this, in making that journey, it seems to be the first barrier to break down is the NPO barrier. And some places start just by liberating the water drinking before they get into the carb drink to just build the confidence on the NPO thing. Tim, you've travelled this journey at Duke.
Yeah, we actually did it the other way around. We did the carb drink, and then once that was started going, then we were able to fully liberate. We just started in the ERAS patients initially, and the two were together. You could drink water 2 hours and you had your carb drink. And then when people were happy with that, then we opened it out to all patients. But it's one of the hardest things I had to change, because you've got to educate so many people to change your NPO status in your hospital, from every nurse that calls the patient, from the pre-op to PACU to the floor
people
nurses.
You meet in the street, to people in bars, to people at bus stops.
Everyone tells them,
everyone
and then their relative says, oh, no, you got that wrong, it's midnight. What are you doing? You're going to get cancelled. And then even though 10 people have told them 2 hours, they still are conservative because they don't want to be cancelled.
Stuart?
And as hard as it is to deal with the patients that are coming in from home, even more difficult to break down the dogma in the institution itself. So I've looked at our patients arriving from the floor, and you've got an intern who's frightened of getting shouted at by the chief resident, who doesn't get shouted at by the attending surgeon because somebody's cancelled the case because the patient's not fasted. So when I actually look at the volume status of our patients that come down to the OR, the inpatient cases, we've got this controlled environment with a messaging about enhanced recovery. People are chugging back their carbohydrate drink in pre-op and taking clear fluids. The message is enforced by our nurses. And then inpatient, where we have control, we've got some of the worst fasting guidelines. So now we're trying to address that in the inpatient care. You look at the causes of death in the United States: cancer, heart disease 1, cancer 2, iatrogenic injury 3. And when you look at these California raisins that come down for emergent surgery, it's really tough to change that behaviour inpatient.
So we're going to get another question, but just to be clear from everyone, the balance of evidence is if you keep somebody starved, the things you're trying to prevent, you're setting them up for a worse outcome from that perspective than a better outcome. So the volume of intragastric fluid and the pH of that fluid is worse in a fully starved patient than somebody who's been taking clears. So if you're worried about litigation in the future, I would worry about NPO after midnight now, because someone's going to get into that at some stage if things go badly wrong.
And it's a metabolic catastrophe because they're heading into a catabolic state before you even start.
So,
hi, my name is Tamana Sumra. I'm from New York. I have a question for clear fluids. Like you're saying, like you allow your patients to drink water. Do you guys go with the volume? Like, we know like for aspiration, the volume is like 25 cc's. And the pH should be less than 2.5. Those are the high risk for aspiration. So you guys are like allowing the liberal use of free volume, like free water, the clear water.
So our protocol is, yes, we allow liberal, unrestricted use of water until 2 hours before surgery, and that is the ASA guidelines. 90% of water clears from your stomach in 20 to 30 minutes. If you have got any residual fluid, which is unlikely, it's actually better if that small amount of fluid is diluted, so it's less acidotic. And the ASI guidelines are clear that you can have unrestricted use of until 2 hours preoperatively.
Since the last century?
Since the last century.
Since we were residents.
And what they allow it, the European and the Canadian guidelines have actually changed the word allow to encourage. It's a subtle change, but they actually encourage use of clear water until 2 hours preoperatively. That's as far as I've done, as we've gone at Duke. What I'm saying now is in the UK is that some groups are pushing that even further and being completely unrestricted. That is currently not within the guidelines, and I don't think guidelines are going to change, but it may be that practice change will drive guidelines. If enough people do that and it's found to be safe in hundreds of thousands of patients, maybe that will drive guidelines. But at the moment, 2 hours, completely safe for water. And we include black coffee in that as well at our institution, because my wife has surgery. The one thing she wants that morning is black coffee, and it's completely safe. And I said, yes, please drink black coffee. And I said, if I'm saying that to my wife, I really should say that to all patients.
Stuart, and then we'll get another question in here. We've got a couple backed up.
And if your patients are drinking in pre-op, think of your pre-op area, the amount of time it takes to get somebody in, get changed. You take a history and get them checked in with EPIC, do your universal timeout. I defy you to get the tube down them any less than 2 hours. It's almost impossible to bring an elective patient now who's been drinking clear fluids up to arrival and actually end up anaesthetise them within that 2 hours.
And it goes on that list of great myths we've perpetuated that are the evidence is flipped the other way round. In other words, we were just electively putting a lot of energy into doing the wrong thing that's a bad thing. It's very hard to unpick. Mike, and then we'll get the next question.
Well, I think, as with several things in anaesthesia, it's a very, very, very rare but potentially catastrophic outcome, and therefore we've been a safety-focused specialty. We've focused all our attention on that and missed the unintended consequence of starving and keeping dehydrated very large numbers of patients. And I think it's almost part of the shift towards perioperative medicine and looking in a much broader context. I cannot remember the last time I saw a significant perioperative aspiration. I see an awful lot of patients. I'm an intensivist. We simply don't see them in our hospital, and I see an awful lot of patients who are dehydrated and have fluid-related problems because they've been under-resuscitated.
And if you're worried about gastric volume, point-of-care ultrasound now, we're going to do this later in the week, learn how to scan the gastric volume. You can give yourself a real sort of sigh of relief and worry less by actually scanning through the patient's liver, looking at the gastric antrum and see if there's contents in there.
Yeah.
A lot of that's been used to develop these new guidelines, actually using it as a tool.
There was also an opportunity to see that it goes up if you starve someone protractedly, which is an interesting thing to watch as well. Top Med Talk. So some great takeaway messages there. If you want to cross-reference any of that to other articles on Top Med Talk, please go into our podcast section on topmedtalk.com. Go into our search engine, and whether it's hypotension or goal-directed or restrictive, put those terms in and you'll get access to a whole host of other podcasts. If you want to come and meet the Top Med Talk team, we're going to be at the EBPOM London meeting coming up shortly. That's EBPOM, EBPON. So go to their website, ebpom.com, and come and meet the team.